We've sort of mentioned transition a little bit, so I want to kind of dig a bit deeper into that. And I feel like this might be a bit of a loaded question because I think I know the answer to this, Will, but clearly there is some challenges in terms of that consistency of transition and really nailing that as a national kind of issue across all rare disease. But um, what needs to happen, or what can happen to give us more consistency of that? You know, we hear so much about young people being really nurtured in that pediatric environment and then almost kind of thrown out into the wilderness of adult services. But we also know that when there are specialist centres in any rare disease, it tends to work really beautifully. So for those that can't sit within that, what can we do on a national level in policy to try and improve that little bit? Because I feel like that is where a lot of young people with rare disease are really falling through the net.
Um, yeah, absolutely. This is a big challenge. It's a broader it's an NF1, and I think NF1 is a really good example of why it's really important. But it's broader than that. It's rare disease, and that's why it's arguably broader than rare disease. It's children with complex conditions, regardless of many of whom have a rare disease. But even if they haven't, um, it's who takes the place of the general pediatrician or the community pediatrician in these individuals. And I think thinking about it as a person is probably oversimplistic. There's different ways one can approach this. So I think there's some recent quite good things. So I think the NICE quality statements for rare disease acknowledges there's an important role for care coordination and that people should have a named care coordinator. Um, and these things can be helpful because they when you're trying to come up with approaches or strategies and get funding, actually having statements to say this is what is considered good practice, um, then that's really helpful. Um, I think some of the work that I've done locally in our region was to try and distill existing guidance and pull out that so that it's primary care specific. Because what we know is ideally there would be an NF1 specialist around everyone's corner that they could engage with, who's really engaged and was well placed to feed into all the appropriate things. But that's probably unrealistic. So we can hope that happens, but it's probably not. But in that place, we need to try and make sure that when individuals are contacting a healthcare professional, that healthcare professional has access at just-in-time resources that are clear, concise, and appropriate for the clinical setting in which they work. So that's kind of what we've done with our NF1 kind of care pathway mapping bit. We took existing guidance, we didn't create new stuff, but we distilled it down to what is pertinent as a GP or as someone working in the community. And also not teaching people how to suck eggs, because often we get things saying, oh, you need to manage this person's blood pressure, and then they start to describe how you need to manage somebody's blood pressure because NF1 can be associated with raised blood pressure. I treat blood pressure every day, so I don't need to be told how to manage blood pressure unless there is something unique and distinct about managing this person's blood pressure because they've got the condition. And there is something unique and distinct about people with NF1. They should be thoroughly investigated for secondary causes, which is not what you do if they didn't have NF1. So that's the only piece of information the GP needs. So you can literally write that as hypertension, one line, otherwise manage as per protocol. And again, we know that there's an increased risk of breast cancer in adults with NF1, so therefore they're offered additional screening. But the screening actually is the same as moderate risk breast cancer. So rather than write a big long paragraph and lost in there is a key message, you distill that down into breast cancer, manage as per moderate risk of breast cancer, which is mammography annually from the age of 40 and the down whatever your standard pathway is. And then flagging the key things that you really need to know about, and when you should be referring and who you should refer on those pathways. And I think this is something that can be replicated across lots of people, so that helps to assist people who are actually seeing patients. They don't need to know much about NF1, but when they do see someone with NF1, they look in a place which is familiar to them. They see a resource that looks familiar because it looks like all their other kind of guidance and pathways, and it directs them to do exactly what they need to do, which is unique, that is different to what they would otherwise do, and where to ask for help and where to refer people to.
Amazing. So it's I guess the devil in the detail is in that handover, isn't it, as well, and that key step there. Lily, I'm going to come back to you again on transition, because we recently met and had a really great couple of days in Manchester meeting with all your young people to talk about transition. Can you talk, because we were looking at all elements of transition, just not medical transition, but having kind of had some time to reflect on that now, what do you sort of hope will be the impact of the body of work that will come out of that and all of the insights that you gave? And were there any surprises when you met with the young people and you heard their other experiences about how everyone's transition experiences had been?
I think it was quite interesting to see how everyone's transition experiences were so different, but also so similar, because of most of us not having always the best transition experience, with hospitals and doctors potentially not handing over in the best way. And like you said earlier, others having quite horrible things said to them. And with the transition leaflet, I think it should be hopefully really helpful, because depending on how it's put together, hopefully people should be able to adapt it to what would suit them best, and they can put all their information in and then take bits out as and when they need to. Hopefully keep it updated, which will be really useful and hopefully help them as a family and community, and when they go to hospital or doctor's appointments.
Amazing. I think what's also really was important and what came out of that was that in the absence of not always things working as well as, the sort of the aspirational that Will's really driving hard to try and happen, where, that information gets distilled, that if the young person also has that information about, for example, their rights for screening, their importance of blood pressure monitoring, then they're also coming at it from an empowered point of view to be asking the questions and to be the sort of advocate for themselves, in the hope that then both sides eventually align and
Yes.
things happen. But you can have a bit of sort of empowerment to take control of it and to know the questions to ask yourself. So yeah, it's an exciting body of work, and I think that what you as a group inputted into that was so valuable, and I'm really excited to see how that really helps drive forward the work.